So I have no financial disclosures, but I do think it's important to sort of name some of my own disclosures. My academic focus is certainly on adolescents, young adults, pregnant people and their families. I'm a family physician. I'm not a psychiatrist or a psychologist. So I come at this from a very different lens of trying to think about this whole family unit. How do we supporting that one person with a substance use disorder? How do we help and support that entire family system, which I know is very aligned with how a lot of you pediatricians also think about things. I'm a parent. Every day I'm trying to be a better one and make mistakes and pick myself up and try to figure out how to make that work better. But I also think it's really important to name that I'm not a person with lived experience with substance use disorders, and I don't externally represent communities that have experienced systemic oppression and racism. And that's really important when we think about substance use disorders, because while substance use disorders universally affect all populations, races, socioeconomic statuses, at the same proportion, the burden of severe infection, disease, mortality are borne by underrepresented groups. For today, in these 45 minutes, I'm excited to touch on a lot of topics, and I hope to give you some tools you can bring back to your own clinics and programs. I would love it as people are signing in. If you want to share out where you're coming from, it's just so interesting for me to learn the different places, and also like if you think your program would like to have further support in this area, I'd love to talk more with you. So my objectives for today are to really talk about how words matter, how do we discuss substance use with families, talking about some of the development risk factors for substance use disorders, how to screen for them, specifically nicotine, alcohol, and cannabis, then moving into talking about opioids and specifically fentanyl, the concept of harm reduction, and then very briefly also some medicines for addressing and supporting opioid use disorder. And as I begin, I do want to acknowledge that a third of Americans have been affected by someone's substance use, so very likely including many of us in this room. And I always just say, like, if you need to nurture yourself or take space from the content, I really encourage you to do this because this is a hard conversation at times. And the stigma in our society really makes it feel heavier. And so, mostly, my hope today is to fill you with the hope that I have and the hope that you can give your patients that I feel every day in this often what feels hard and isolated space. And I think for many of us, learning comes not just from slide sets and research papers, but really in people's stories. And for our talk today, I'm going to share a couple of scenarios. These are not real cases, but based in my real experiences. And so I imagine they sound like some of your patients, but are not real scenarios. So in this first case, you're about to see a 6-year-old patient, and the reason for the visit is trouble paying attention at school. While reviewing the chart, the history says the parent was a drug user exposed to methadone in pregnancy. And I think there's a lot of things that sometimes we see in charts. And I just think I take a moment to pause because I imagine that some of you have assumptions now that even just hearing this much. And does this sound like a story that you've heard before? It makes you think about the home environment. What's that been like as this child, the 6-year-old, is growing up? Would we feel differently if we learned that they'd been exposed to an SSRI in pregnancy or an antidepressant in pregnancy? And so I know while this talk is about adolescence, so many of these conversations we have, they really can and must start much earlier, and specifically how the words we use matter. So I think it's important as we reflect on this case, it brought up some preconceptions about substance use in pregnancy, and I wanted to clear up some of the myths about how substance use in pregnancy may or may not have an impact on this child. So, one thing to know is that cocaine, crack, and meth in pregnancy are not known to cause significant cognitive or developmental concerns for children. And I think that that's different than what a lot of people expect. And similarly, opioids and fentanyl during pregnancy are not known to cause significant cognitive or developmental concerns in children. I think that really rocks at the core of what a lot of people expect because these are hard drugs. They must be really, really teratogenic and problematic. I will say it's hard to do these studies to understand what is the impact of these substances specifically, because the things that we do know are that living in a chaotic home, living in a home where children do not get the attention, responsive parenting that they require is detrimental. And it's sometimes hard to tease apart what are the pieces that are related to substance use and what are the pieces that are related to a chaotic home environment. And, but I think that this is some of the stigma that we have when thinking about the substances themselves as being the drivers of desperate developmental concerns, which is not borne true in terms of significant effects in the literature. What we do know, and I know everybody on this call is concerned about, is about the role of alcohol, tobacco, and cannabis. Those have been extensively studied, and exposure during pregnancy has been associated with cognitive concerns in children. And I think that that's really important. I think it's really important than for us to lay out the legal substances that are most concerning. What we really do know is that most substances, including fentanyl and crack and meth, they certainly impact a baby's growth and can make them be born early. That's true also of alcohol, tobacco, and cannabis. And I think is something those are clearly things that we're trying to figure out how to prevent and have baby develop longer and be appropriate size. I always think it's really important to share out the babies because addiction is the consequences of substance use. Babies are absolutely not born addicted. They do have tolerance and have withdrawal symptoms in the transition after birth, but they're not addicted, and that's not a word I would ever use. And also, I think it's really important to say out loud that parental use of medications for opioid use disorder is entirely protective of that parent in preventing overdose and protective of that family in what is otherwise a cycle that can be really chaotic and hard to break through. Regardless, I think that these are essential pieces for us to know and to reflect back to patients because it's not only us as providers who have the stigma around how these substances affect development and families. Parents and children, people in the community have the stigma as well, which is part of what delays people from getting the care that they need. I do think it's really important to talk about why the words we use really matter. And when I've done this talk in community members will be like, Lauren, stop here. This slide. They'll be like, go back to that one slide. This is the slide that means most to folks in community and how we can create spaces to really be welcoming and loving for all families. Instead of using the word drug abuse, I never use that. I always talk about use or misuse of different substances. The word clean, a lot of patients use that too. I never use that in particular. It has a lot of different connotation. Instead, I talk about being in remission, being in recovery, being abstinent from substances, or that your urine test was negative for different substances, or urine testing consistent with prescribed medicines. A habit implies that somebody has power to change what's going on and change how the brain changes that we know are extremely real do not make this much different than a habit. This is truly a disease. This is a substance use disorder. Using words such as addict or user, I think really I discourage people from using that, using person first language. This is a person with a substance use disorder. And also, as we talked about a little bit earlier, the concept of addicted baby. I talk about a baby born to a parent who used drugs while pregnant, a baby with signs of withdrawal, a baby with neonatal opioid withdrawal symptom. All of those are better ways to really describe what's happening. I just challenge you, it's interesting. I think it's often in professional settings, you're like, oh yeah, I never talk like that. I never say that, which I believe. And it's interesting. I think it's often in like the more casual conversations, the sign out that we have with our medical assistants and nurses, the conversations that people have where these terms kind of float in. And so I encourage and challenge everybody to identify that within ourselves and think about how we can use different language to support our families. And so the words we use matter, and I would really argue that the words we chart matter. And so imagine if in the same case, the history were to say the pregnancy is notable for maternal opioid use, stable on methadone, and now in long-term recovery. What a powerful thing. And understanding a parent or family's substance use history is so important because it does have implications for this developing child. And this is what I call a moment to really plant the seed. This allows us to have the next conversation to help them when they're adolescents. So I really I really ask families openly about substance use in all of the well child care that I do. I say, has anyone in your family ever struggled with alcohol or drugs? Right? I think struggle is something that we can all relate to. It doesn't necessarily mean they've had a substance use disorder, right? With that full diagnosis, it means that they've noted some hard consequences of substances, and that's really that's something that's important to note, and that we should be able to care for with families. I like to set the stage for questions. That substance use is so common in our communities. Let me know if you ever have any questions, because you want to create space, just like we do in so much screening. We're these drops in the bucket so that people can feel welcome to talk with us when they return the next time. Really setting that stage for transparency and openness. And honoring what's shared. It's hard for a parent to say that they've struggled. I'm so impressed by all you've been through. That's strength you're passing on to your kids. And that's real. Even when people are struggling, I offer and try to identify those strengths in terms of, I see, but you showed up for your appointment with your kids today. I know how much you care for them. Like trying to honor and recognize that it's in these small steps that people are trying to still nurture and support their families. And in taking the next step, I really, within the right family, and in honestly, for me, most all of my well child checks, I'm really encouraging families to talk about their substance use with their kids. Don't let this be stigmatized further. I say things like, sometimes substance use does run in families. That's really true. And it's important to know that so that we can keep your kid, so that we can keep your kids safe and they can experience different struggles than what you've gone through. I really take that as a moment to join with the parent or family member, because everybody wants the kid to be healthy. How do we help? As parents, it's always about, how do I do those great things that I did with that I got to do as a kid? How I do those again with my own kids, and the hard stuff that I've experienced in my life. How do I protect that? How do I protect my kids so they don't have to have those same experiences? And really trying to connect with folks in that way and utilize this as a way of transparency and support that kids can learn those lessons. And asking permission, even if people aren't ready to talk about it in that space, saying, can we keep checking in about this when we see each other next? Because I want this to be a continuing conversation where they know this is safe and that's safe for things to change and be different. Now, going back to our case, we now have more understanding of where the family's coming from in their concerns for their child's attention at school. So the parent shares that the school believes that the child should be evaluated for ADHD. And the parent does say, I agree. I've been seeing some of these same behaviors at home. I've been a little bit worried about it too, but listen to me. I don't want you to give my kid any stimulants. I'm not about that. My family, we don't give those type of medicines. And I think that for those of you in primary and outpatient pediatrics and primary care, I think feels pretty true that you've heard that before. I wonder what your reflections are on that. And I think that, and I think really thinking about, like, what are your own thoughts about the connection between substance use and ADHD? Have you heard things about that? And do you think that the parent's right to be concerned about stimulants in their child? What we know is ADHD is a wildly common childhood health condition, and it is associated with higher rates of substance use. A diagnosis of ADHD does place people at slightly higher risk of having a substance use disorder in the future. But treatment of ADHD with stimulants is not associated with a higher risk. And indeed, a number of studies show that it's protective. That early diagnosis and appropriate treatment for ADHD is protective for kids in developing future substance use disorders. And I think that often is different than what our larger community thinks. But it's really something I think is really important for families to understand. And it may still not be the right thing for that kid. Family members may still feel strongly. And I think that that's always a shared decision. But I think it's really important to know that if the concern is about them then developing a problem with substance use disorders, that we need to make sure we're giving evidence-based truths around that protection. What other things do we offer that seems protective for substance use disorders? And so now that we talked a little bit more about that family history, let's transition a little bit more into the considerations of what's happening in adolescent development, and we'll do that through another story. So this is now a 15-year-old that's coming in for well child care. On their screening form, it's marked that they're smoking cannabis. They share that they first smoked marijuana at age 12, given by a non-parent family member, a cousin, to help relax. Now they're smoking a couple times a day since going back to school this year. And so I think some of you may think, okay, that's pretty normal for adolescents. Or maybe others are like, oh my God, this is horrible and terribly alarming. I mean, that's the interesting part about weed and cannabis is that we're finding people on different polarities in terms of their reaction around what is normal and what is safe. And I think with cannabis legalization in particular, this conversation is coming up more and more for me and certainly with families I'm working with. In thinking about adolescents, understanding the brain development is so important. So bear with me as I think a little bit about that adolescent brain. I'm sure a lot of you have seen the same graph because it's at this time in development. I'm thinking about two different brain structures: the limbic system, or the nucleus accumbens. That's the reward center, the drive to seek out new experiences, try new things. That develops quite early in adolescence. Whereas the prefrontal cortex, the executive function, that's what really that considers the potential risks of different actions, that's taking a little bit longer to develop. And so that means that there's a lot of drive to do impulsive and try new things, but not necessarily thinking about the consequences of what would happen. And it's a developmental drive to hit the gas and with an underdeveloped brake, so hard to slow back. And it's really a setup for experimenting with substances and could have much longer lasting implications. When I think about that brain development, it makes sense then that the people who develop substance use disorders start their substance use as teenagers, with the average age being around 19. And it's extremely rare for substance use to start after the age of 25. And this is striking, and it affirms that why, in so many ways, addiction is truly a developmental disease, largely driven by this gap within the developing prefrontal cortex. And that's part of why I'm so delighted to talk about this with you all, because it's part of your work matters in caring for adolescents and youth with substance use, because this offers us the opportunity to have a different path besides developing use disorders. And because offering support and guidance, it definitely improves outcomes in the years ahead in terms of safety, in terms of reduced use, and options for future betterment. Understanding what the different risk factors for a substance use disorder, I think, is also really important. There are four different things I think a lot about when I'm working with adolescents, in addition to like diagnostic criteria for substance use disorders that really can put people at further risk. Early experimentation, especially before the age of 14, is associated with much greater likelihood of developing a substance use disorder in the future. And indeed, every single year that a person ages, that risk goes down. So counseling a patient to, what about taking a pause for a little bit? That time matters. Giving people a break is a huge part of what I do in my counseling, and talking about how do we create space for these breaks to allow your brain to develop more. Family history is key. Genetically, there are risk factors that are shared, that are associated with substance use, and that's a huge part of understanding somebody's risks, is knowing what's going on in the family. Family history also means that there's potential availability and accessibility of different substances that's different in that family. Adverse childhood experiences has long been associated with not only substance use, but higher risk use. And co-occurring mental illness, those with depression, anxiety, bipolar disorder, certainly are at higher risk of developing a substance use. So what do we do with our knowledge of these risk factors as providers? I think the first part is to ask all youth about their substance use. So how do we screen for it? I think we can't, if we don't do it as a part of a standardized screening process, we are going to be very vulnerable to implicit bias and asking some kids, but not all, which means we will be missing substance use. A standardized screening that we often use, we use here at HCMC, is the Screening to Brief Intervention, S2BI. There are other ones called the Brief Screener for Tobacco, Alcohol, and Other Drugs. All of these have been validated in youth, quick to use in the office, and really can help do a quick identification for who's experimented and how we know about that. I also think it's really important in that process to review confidentiality before we talk about the results, review it with the family member in the room so that they understand there may be stuff that this kid is going to talk about that I'm not legally obliged to tell the parent. And I think that that's something that's really important to say upfront and again, so that the youth understands where your line is, and also so the parent isn't surprised that there may be conversations happening. Now, that said, I always encourage my youth to let's come together and how do we want to talk about about this with your parent, have a shared plan so we can have that discussion. Because I think, and really trying to honor the fact that this kid was willing to open up and say something. I always ask people, when somebody's like, this isn't me at all, I always am asking about, like, tell me about your friends. What's going on with them? Do you worry about your friends and what they use? And then kind of flipping that, do you ever worry about yourself and how this fits in? I think there's a lot of ways to warm up to those different conversations. And if somebody shares substance use, we're going to honor that the patient felt safe to say that. I appreciate you saying that and being honest, and affirm our commitment to supporting them to be healthy. This is a big deal. They are expecting, as an adult, you are going to tell them, stop that foolishness. For you to come to them and be like, I hear that you're experimenting with such and such. I'm with you to help figure out how to make this as healthy as possible. That to them is, who doesn't want to be healthy? They want that too. They want that too. And I think that that makes it a more approachable space to be able to work in how to get to the point of stopping. I also think, as we talked about, reviewing the protections during adolescence, I want you to know that when you're a teenager, you have special confidentiality protections around substance use, very similar to sexual activity and contraception. And I just want to remind folks, be curious and don't assume. Kids use all sorts of different terms around substances that I never understand. I'll be like, wait a second, I want to make sure I'm getting you right. Can you help me? Tell me, what does this mean? What do you think that is? You don't know? Let's Google it together. Because I think that there's, with these different names and things going around, kids don't always know exactly what it is that they're using. And even that can be an intervention that's helpful. And ask permission if you can ask more questions, and then offer ideas. I always ask permission. Can I share my thought with you on that? To make sure that they understand that they are in control of that situation, and the promise that we're going to be able to come back to it later. I think a big thing, and you've all probably used this fairly regularly, is the CRAFT screening. This really helps gauge, how worried should I be? Right? Have you and knowing that if you're at risk with greater than 2, or if you have more than 4, that may be more concerning for a substance use disorder. Thinking about, have you ever ridden a car driven by somebody who is high? Do you ever use alcohol or drugs to relax? Do you ever use alcohol or drugs while you're by yourself or alone? Do you ever forget things while you're using? Do your family and friends ever tell you should cut down your drinking? Have you ever gotten into trouble when you were using alcohol and drugs? That gives a good foundation so you can understand a little bit of, like, do I worry about you, or should we talk about this the next time? Independently, I'll say I recently was working with a team from Boston Children's. One from some of the studies that they've been referencing, they also allude to if a teenager is having blackouts from alcohol use in particular, that independently is associated with much greater risk of a substance use disorder, but also more brain deficits as time goes on. And I think that that's something that all of us as a screening question should be asking our kids, to be able to elevate that concern and support them in their ongoing development. And please, folks, do put out in the chat if you think I'm going too fast, or you have something you want to ask a question about. Very, very appropriate. This is the point where I usually I sort of open up and say, can I offer you some different ideas about what would be helpful in regards to your substance use? And at this point in this talk, we've talked about the importance of our words, how to talk with families about substance use, how to screen for substance use. Now I want to talk a little bit about some of the ideas that you can provide when a patient does disclose use. And the first and most fundamental step is to create a safe space where they can come back and get support, not feel judged or preached to. This is about safety. How do we make this safer? And the second is to really lean into what they think would be helpful, because if they think something's helpful, then that's half the battle, right? If they believe that can be beneficial. So we'll jump back to our last case. And we learned a little bit more about this 15-year-old, because you gave them that wonderful screening form and they were like, yes, smoking cannabis. They shared that most recently they started smoking a couple of times daily with friends. They can go a week without smoking. They deny specific cravings, but really just like how it makes them feel, which is more calm and more social. And they really deny any mood changes when using. So we already have like a couple of things that we're thinking about here. Young age at initiation of cannabis use, potential family history, right? Who's this non-parent family member? I didn't disclose that, especially, who's that? And now there's like increased frequency of use. We've also learned more about their motivations. Why are they using? And all of our behaviors usually start with a reason, and it's an understanding that we can really offer better support. And so, especially, I always ask, well, what does it make you feel? What does it do for you? Because what I want to create is a sort of like a toolkit with different things that you can pull that's not always just a weed to have that feeling or address that concern. That there are other tools, whether it be mindfulness, whether it be hydroxyzine, whether it be some different things that can help you, that you have a number of things besides relying on one specific thing to have to address that anxiety, nausea that you're feeling. And I want to think a little bit for a moment about how common use of nicotine, cannabis, and alcohol actually are in adolescents. So this is data that we're going to look at from national surveys of 12th graders in 2023 who report that they tried alcohol, cannabis, nicotine. And that means like inhaled once, took a sip of alcohol, even folks who just tried to use substances. And so for alcohol, that sip was 46% of 12th graders. Only 29% of high schoolers took a puff, at least a puff of either smoked cannabis or edibles. 23% had used or puffed on nicotine vape, 6% on a true old fashioned tobacco cigarette, and 4% on these really candy looking, appearing nicotine pouches that I'm amazed exist and look so much like bubblegum. I think that what's notable is like these substances have decreased substantially since the pandemic, and yet the risk of these substances are really not small. I do think that if I imagine some of you had anticipated higher numbers, the amazing part is that you think everybody else is using besides them. And so when you ask youth how many of your classmates do you think are using weed or cannabis, it's greater than 50%. Like the perception that everybody else is doing this, which is not really founded. And so I love to share these actual numbers with folks around where that is. For those of you who've heard about gateway drugs, there is truth in that. Studies show that there is this brain priming, that the use of nicotine, cannabis, and alcohol can increase the risk of other drug use. That's definitely true. We know that the availability of substances makes it much more likely for a youth to experiment. And also that the frequency, ongoing recurrent use increases the risk of future substance use disorders. And cannabis in particular, I always feel like we should hold space for because it is associated with much higher rates of psychosis as an adult when you use frequently as an adolescent, much longer lasting effects. And of course, I think as those of us who work with folks with severe and persistent mental illness, this greatly alters a person's future potential success. So, how to respond to nicotine, alcohol, and cannabis? I think we started with this case of a youth smoking weed, trying to really understand what that reason, we talked a little bit about that already, like what's the reason that they're using it? They feel it serves some purpose, and trying to understand that to offer other options. Several people will identify, they'll be like, well, I self-medicate because of such and such that happened. And many have a belief that because it's legal, it's a safer thing, which I really disagree with, as we talked about earlier. Sometimes I do hear from adults, well, I used to do that and I turned out okay. It's also true that substances are so different now than in the 80s and 90s, folks. Weed is at least 4 times more potent of THC than it was in the 90s. And it is a very different experience as a youth today in terms of accessibility. So, how to respond to some of these concerns? I actually really like this mnemonic, which is weed. I find it to be helpful. Welcoming questions about use, being that this is a safe place to talk about this, explore alternatives for common concerns, their purposes for using, explain the potential risks, and deliver a harm reduction message recommending a decrease in dose or frequency, trying to help folks figure out how do we nudge this down. And so I hope that's a tool you can bring back into your practice when you're thinking about considerations. And I think there are also more considerations for us to think about specifically with opioid use, which will bring us to our next case. Actually, one other thing I'll say out there for folks is that there's an app that was recommended to me by some of the Children's Minnesota folks that they use it's called Grounded. It's an app intended for young adults and teens that helps intentionally like cut back the amounts, do some of that motivational interviewing. So that might be something to check out as well. Our next case moves us sort of more into opioids. And um, and that we are so now seeing a 19-year-old for help with opioids here with family members. The family members are bringing him in very, very concerned. He says that 5 months ago, they started smoking blue pills. Started first with one pill now and then. After a couple of weeks, was smoking daily. They planned to only smoke through October, but then couldn't stop despite trying to cut down. And the family, like I said, is just like beyond themselves. And so I wonder what your reflections are about this situation. And if others had family members that are asking, like, why can't they just stop? Why don't they just stop? And I just think we get so many mixed messages about drug use that gets really confusing. Um, for example, on one hand, we're hearing that adolescent drug use is lower than ever before since the pandemic. And yet, at the same time, the mortality from overdose has risen so dramatically that largely due to fentanyl and synthetic opioids. And so it's that quandary. It's like, well, use is down, but the risks of using are higher. So let's transition to talking more about fentanyl and other opioids and why they're different and how we can help guide that teen and family from our last case. I am going to show some pictures of substances here as a warning and disclaimer. So fentanyl is a synthetic opioid. So that means it can be made in a lab. It's 50 times stronger than heroin, which is derived from poppy plants. This picture shows a lethal dose of heroin and a lethal dose of fentanyl. Clearly, much less is needed of fentanyl to have a huge impact. Fentanyl often looks like this. Pressed blue pills can be smoked on foil, crushed, snorted, or injected, or it comes as a white powder, which is really tricky because a lot of different substances can be accidentally included in white powder or in pressed pills, which makes it all the more dangerous. And like I said, I'm often asked, why don't youth just stop? And so I wanted to share a graph with you that I often share and draw out with families to help them understand what's so different about opioids. So this is a graph on, you can see on the y-axis, so that's the opioid level in somebody's body, whereas the x is time. And so from the moment we're born, we establish a homeostatic level of natural opioids that our body regulates to. Okay. We have this normal variation. Some people call this type of opioids endorphins. That really increases and decreases with the different activities going on. I think about the little bump up is the times when you think back in your memory and you had a fabulous time with your grandmother doing something really special and where you felt just really nurtured and loved. And those times when it's lower as a teenager, when you're more isolated and alone, feeling those ups and downs of those moments. And I will say, for folks who've experienced adversity early in their lives, that looks different. That up and down and regulation is different, and part of what potentially is putting people at more risk. But from the moment that some people use an opioid, it completely dwarfs that opioid level that comes with the first time use of fentanyl or heroin. Or honestly, oxycodone from your wisdom teeth extraction. Some people feel this differently. It totally outsides. It feels so different, better than the best time ever. I call this the heck yeah moment. And it covers you up, that deep blanket, so you're forgetting the hard stuff that you've been through. It's unlike anything else. So it's a really natural human response that then people are like, I'm gonna do that again. That was amazing. And they do, but the next time it's just not quite as good. So they're gonna use a little bit more, and they fall into this cycle where then suddenly the body's like, oh, you're getting opioids exogenously. Well, guess what? I'm not going to make it anymore. That natural homeostatic, the amount of natural opioids being produced from the body decreases markedly. And instead of trying to get anywhere near that heck yeah moment, it's people move into trying to feel normal. So if you can see on the graph, the low here is so much lower than that alone, isolated, depressed time as a teenager. This is unparalleled discomfort, physical restlessness, anxiety, worthlessness, feeling deep body aches that your body is dying and that you are trying. And so using helps you get to a place where you can be that normal person that you just need to use a little bit so you can get to the grocery store today, so you can still keep your job. And I think that that's the difference that introducing a medicine like buprenorphine or methadone is, because it's not about getting to the heck yeah moment. It's about getting to your homeostatic baseline that you were born and established as a kid so that you can get your kids from school, go to the grocery store, keep your job, pay your rent, and not wake up in the morning and say, what am I going to do with my body today so I can feel okay? That is the difference of how these medicines. That's why these medicines is not trading one substance for another. This is why you can't stop. It's because you can't find that baseline. And the other benefit of these medicines is that use of buprenorphine and methadone overall reduces overdose by 70%, reduces transmission of infectious diseases, increases engagement in primary care, prenatal care, all of these different things, and offers a hope for future. I think a lot of people ask me, well, like, does that level go back to normal when they stop using? The research doesn't really know. We don't really know. I think some people, a third of people, are able at some point, 6 to 12 months later, are able to taper off of buprenorphine and methadone and go on with their lives because they have other things supporting and fulfilling them. A third of people try to go off and they're like, nope, that's my seatbelt, going to keep that on, keep me safe because I've been doing great on it. Why would I mess up what's good for me? And a third of people, even after that long stretch of abstinence, have a return to use, and we pick them up again and to try to figure out what they need for that moment in their life. How to respond when somebody's telling you about their opioid use. It's the same as if everything you were going to honor that this patient felt safe to share this. You're going to affirm your commitment. I want to help you be healthy. This is a safe place where we can help you find options to make you feel better. And that we're going to share 3 key options that are available for kids: harm reduction, medication options to make them feel better, and substance use programming where they can find other community to get support. Harm reduction, for folks who aren't familiar with that term, it's a really amazing thing where we're thinking instead about not just stopping, it's about how do we decrease the negative consequences associated with drug use. How do we make this safer as a first step? So, like, if you can't tell a kid to stop entirely, how do we make this so that they're less likely to die? Because that's the stuff that we're often up against. And I think what I love, especially about this wonderful article from Pediatrics, was the articulation that in pediatrics, we're not just talking about the kid, we're talking about their peers, we're talking about their family. This affects everybody. And at every opportunity, talking about harm reduction, talking about how to access care is exceptionally important because it's this more than just that one person. It's their much bigger community that's being affected by this child's substance use. Harm reduction also has a bunch of different elements that I think I'll just highlight quickly here. A big one is prescribed naloxone or Narcan. This is key, helps our overdose mortality in recent years, has no effect on people who are not using opioids. And please tell people this is safe with infants. People need to know that if there's any concern for overdose, and even the very youngest among us, that Narcan is safe and effective. It very quickly can save somebody's life. The other thing is never use alone. I talk about this all the time that when you're in an unfamiliar place, your risk of overdose is so much higher. Having someone with you, taking turns when you use, or even using a hotline like Never Use Alone can save people's life. Never Use Alone, you text them the address where you're using, you tell they have you on the phone, they check in with you periodically to make sure you're still with it. If you can't respond, they call EMS to get help. I often tell people, I think often people are like, yeah, I use with my friends. And I'm like, well, take turns because then you can see how it affects them. You can save them, they save you. Fentanyl test strips are a newer thing for a lot of folks. This is for people who are not wanting to use fentanyl, but not sure if it could be in the supply of other things that they're using. Fentanyl test strips are key. The one thing to know is that it's the opposite of a pregnancy test. What that means is if somebody has a fentanyl test strip that has 2 bars on it, 2 thumbs up, that means safe, no fentanyl. 1 bar means that fentanyl is present in that substance. So I think doing that extra coaching is really important. Other key parts for us to think about are going to be safe use supplies. That means offering clean needles through syringe exchange, clean pipes or bubbles. You don't need to be an expert in this, just to know and ask that they and to support that there are places where they can get them. Safe sex supplies, huge to prevent STIs. Like I said, a lot of people have are doing other things in order to not feel that horrible. That includes trading their bodies, and that's where having access to safe sex supplies is huge. Big push for PrEP. I use it among adolescents with regularity. Prevention in a pill. Please remember, for medications for opioid use disorder are key, and that without medicines, over 85% of people return to illicit use. That in and of itself, when would we ever do something without an 85% with an 85% risk of failure? This is where our intervention and where communicating with families, helping them understand the stigma, helping them understand how medications can help is huge. Kevin, I adore you for putting your question in the chat. What is the mechanism of the fentanyl test strips? Why is it backwards? I'm actually sorry that I don't know the real science behind it. I don't know why. It's somehow in that immunoassay in terms of how it lights up that it changes that reaction. So sorry that I don't know. I could try to look that up and connect in with you. Kevin, I know, is an adolescent fellow at the University of Minnesota. So that's a great research question for me, Kevin. Thanks. Um, Thinking more about medications for opioid use disorder, recognizing where we are with time, there are three key medications. The first one is buprenorphine. It's a partial opioid agonist, and it goes either under the tongue. There is an injectable that lasts 28 days, and people need to be in withdrawal in order to start it. And I think that's a big thing when thinking about precipitated withdrawal. For all pediatricians, I think it's really important to know that there are three reasons that buprenorphine is amazing. One, it helps people feel better from their withdrawal symptoms. That's what they want in the short term. What you want as the provider is when Suboxone or buprenorphine is in the system, people are less likely to overdose. So if you take that Suboxone and then you use safer situation than it was when you didn't have the Suboxone in, it rests on those opioid receptors and blocks the fentanyl from coming in. The third is even if a kid stops Suboxone, they're taking it when they're in treatment, they run away or leave. If they've had Suboxone, that's built up their tolerance. So if they have a return to use, their risk of overdose is still less than if they were on nothing during treatment and then ran away and had the same scenario. I think that's key and I talk a lot about that with CPS, that if you have this medicine on board, we have a lot of protections that we don't otherwise have. We don't need to imprison kids for using substances. This offers us another more natural consequence in terms of they don't have the same effect when they do use. Option number two is naltrexone. Naltrexone is an opioid antagonist. I think of like Wonder Woman and those, blocking every opioid that comes in. It's a pill that lasts 24 hours or a long-acting injectable for 30 days. That's Vivitrol, often used for alcohol use disorder. The downside of this is that you have to be 7 days without using any opioid in order to get it. And guess what that means? People can't last 7 days. It's very rare for me to actually get somebody to a point where they're able to be on naltrexone. And then the third option was it's available rarely for adolescents. You have to apply to the state for a waiver. Is methadone, which is a full opioid agonist. It has a 72-hour half-life, which is why it lasts and works so well. You can start at any time. You don't have to be in withdrawal, but you do need that special waiver from a methadone clinic. It cannot be prescribed from an office. Those are still federal regulations that we have from the 70s that restrict its use. Really hoping to get more access in the near future for folks with methadone. Buprenorphine can be tricky to start. I think that it's important that you ask when the last use was. I'll just run through this super quick. And if it's greater than 24 hours and somebody has a COWS score greater than 8, COWS is a scoring system. You can ask patients different questions to know how in withdrawal they are. Then you can give somebody a full dose of buprenorphine without worrying about it. If it's less than 8, you go a little bit more slow. And indeed, you start with a quarter and then move by quarters up until you take a full 2 milligram strip, and then you can move on to the 8 milligram strip. So really happy if Minnesota AAP would like more of a talk about how to start buprenorphine, especially in the age of fentanyl. I'd be really happy to talk through that. Some things just for folks, I think common scenarios for primary care doctors. You have a patient who started on buprenorphine in the emergency room. They're in your office needing a refill. Please give it. It will save their life. They know how to take it. They want that continuation. Anybody with a DEA can give it. No waiver needed. It's really safe. If somebody is saying, oh, I only use sometimes, then maybe naltrexone would be a great option. You give that injection, it lasts for 30 days, and it has that opioid overdose protection for the occasional person who's using sometime. Person who's snorting coke, doesn't want to use fentanyl, but are worried that it's in their coke. This would be another great indication for naltrexone as an opioid overdose protection. And somebody who's like, I just have such bad withdrawal, I can't do anything, I have to keep using because I just keep getting so sick. That's where buprenorphine is super. For folks, if you are wondering what to do, you have a kid in your office, please remember Minnesota's psychiatric assistant line run out of Prairie Care. My wonderful colleague, Dr. Sarah Pauly, is a child and adolescent psychiatrist and addiction physician. She is the consult you can call, and she will help walk you through what to do. I would also love to be a resource informally. Make sure you have my email address if there are any concerns. I'll just really quickly say, of course, substance use treatment program is really amazing, offers opportunity to connect with others, reflect on triggers, really dictated by a kid's insurance, what they have access to, but it allows you to help. But when you can find that access, it gives extra space and support for kids using substances. The one thing I'll say is there's just not enough of them, not enough treatment programs, and it's not consistent that all treatment programs actually follow evidence-based practice, which is also really, really challenging in terms of some of the the messaging that they're giving our kids as well. So, in summary, we talked a lot about really great stuff. I mostly want everybody on this call to know that you can do this work. I do this work because I know young people who use substances have full and beautiful lives in front of them. And I know that you can create that space for them too. We want to create that safe space where a teen can feel comfortable coming back and asking questions to get real information and not misinformation about this. You can do this. I know that those in this room are committed to doing so and partnering with young people to find a safer path. Thank you so much for your time. I do have an adolescent dedicated clinic for adolescent substance use here at HCMC. Welcome your referrals, your questions. Love to be a further resource for folks as time goes on.